I spoke at the last PulseSafe conference in November, so I think a lot of you will have a good general background. So I was just going to dive into a little bit more of the detail today, and aware that I've only got 10 minutes to do so. Yeah, let's see how we go. So as Adam has already ripped off my slide, National Biosurveillance Network is outcome number 9 as part of the BSS, and that has obviously got us started on this road that we're currently on. So we are just over halfway through since our delivery partner came on board, PA Jacobs, who are sitting over there. And we've been working on what the vision and definition of the National Biosurveillance Network is, and trying to get it onto one slide, which has been really, really tough given the breadth of what is possible. So this is where we've got to at the moment. It's still a work in progress, and we feel that it's going to evolve over time. But it does give us a kind of nice view of where we're at. And for those of you that heard my speech last time, it's all about not reinventing the wheel, but understanding what wheels are out there and how we join them together. So we're obviously in the One Health space, which is a massive part of the BSS and one of the reasons for its refresh. But what we want to do is use the One Health approach to improve and unify surveillance data on the health of people, animals, plants, and the environment to make insights accessible to multidisciplinary group of experts who will then assess and characterize the threat level for decision makers. So the box on the bottom left there, the One Health approach and culture of collaboration. So we want to bring together government, academia, and industry, because we see those three areas as being absolutely vital to breaking down the kind of silos and walls that we sometimes operate in government. And then faster and more efficient. So we want the NBN to facilitate new and existing detection methods for pathogens and other areas in those One Health areas to bring together and understand what high consequence biological threats might be out there. And we can then assess and characterize the threat levels by bringing together the multidisciplinary group who will look at the insights from the data. So we're not talking about sharing raw data between departments. We are still talking about the experts and the specialists in DEFRA, APHA, VMD, looking at their raw data, providing insights, and then we bring that together with the insights from UKRI, who are obviously looking at the human side as well. And then ultimately that provides the decision makers with the information that they need and when they need it. So to Adam's point, the people who are looking at the information in the Cabinet Office aren't necessarily qualified to look at raw data and interpret it. We need to make sure that they are confident with the data that is put in front of them. And we are hoping that in doing this with the NBN approach will allow us to do that. And the BioRadar was mentioned earlier. The BioRadar will become one of the customers of the NBN. How that information gets displayed is going to depend on what people are looking at, but we want to make sure that they have the right information at the right time and they are comfortable and confident with assessing the information. And then the Cabinet Office can potentially link in other information such as mobility or economic data to further inform the decision making. So in order to bring this into reality, we have chosen tick-borne encephalitis, which is probably the first time I've actually managed to say it, as a case study. And it is slightly controversial because it doesn't necessarily bring in what's the word I'm looking for? The excitement of something such as respiratory, but we are 18 months away from having to, less than that now, from running out of funding. And so what we want to do is be able to demonstrate that the NBN is worthwhile in pursuing using this as a case study. And it obviously covers the One Health agenda, plus it brings in climate, because climate change is having an impact on the vectors that are coming into this country. And as you can see, I've put some lovely pictures up there of different vectors. And this is because Tamsin keeps putting up cute pictures of pigs and cows and things. So I thought everybody wanted something a bit different. What it also allows us to do is enables us to test a range of NBN functions to develop a proof of concept. We have some data in UKHSA, we have some data in DEFRA. We can bring that data together. We don't need to go out there and get new data. So that means that we are already on the way forward. And I think that's really, really important. There is already collaboration going on between the tick specialists in UKHSA and the tick specialists in DEFRA and VMD and APHA. We know those conversations are happening, but we know that we can make things better and we can make it a more efficient from an operational point of view. There is also the buy-in between UKHSA and DEFRA in order to pursue this. So that is again another box we can tick in order to move forward. It's not just a box ticking exercise, but it does help. We're also going to use the NBN to add value to quick wins. So in analysing the processes that happen at the moment when conversations are happening between APHA and UKHSA, we can understand how we can make that a more efficient process and bring those experts together in one space. And ultimately, for vector-borne diseases, there's lots of surveillance that goes on in sentinel animals, and that is going to allow us to improve our usage of a surveillance element of NBN to look for those symptoms. So it's a slightly different way of doing things as well, which I think is good. The next slide is really boring for you all, I'm sure, but this is the program update as to where we are at the moment. We're kind of in the middle there. We've taken an approach to try and break down the program into the vision and strategy, which we're working on at the moment. We're also building out the target biosurveillance experience so we can explain to people such as yourselves how this is going to work. And alongside that, we've obviously got the stakeholder and communications plan and the roadmap for Alpha as it goes on. And we will move into a new phase next financial year, which will be Alpha Phase 2. And the final slide is really, really important because it's about us having one team. As I said, the team are sitting over there on those two desks, which is absolutely brilliant because we are not working as a UKHSA and a DEFRA and an APHA and a VMD. We are all working together along with our delivery partners, and that absolutely brings more value to HMG. Thank you. Is that okay?
Yeah, thank you very much, John. Yeah, Isabel stayed sat down, so you did fine. So brilliant. Right. So biosurveillance initiatives, like London buses, there's none, and then they all come along together. So the next thing we're going to move on to is Yogesh, I think, is going to come and talk to us about Genomics of Animal and Plant Health Diseases Consortium, so GAP-DCII. Thank you very much, Yogesh. Over to you. 10 minutes.
Hi, everyone. I'm excited to present here GAP-DCII program. My name is Yogesh. I'm based at APHA. GAP-DCII program is funded by DEFRA and UKRI, and we launched this program last year in July. So we did not have enough time to generate the data. So what I'm going to present today is an overview of this program and how this program fits with other biosurveillance programs. So yeah, GAP-DCII is consortium-led program. We have 7 different partners involved in this program: APHA, RVC, DEFRA, FERA, CFAS, Forest Research, and Purbright Institute. Majority of these institutes are part of DNA Center of Excellence group, where they have shown capability on genomic surveillance program in different work scheme. However, the part of this program is to bring these expertise together and develop synergy and uniform approaches for genomic surveillance methods. So the way GAP-DCII is structured is we have 5 different work packages and 2 other work packages on project coordination and community outreach and interagency collaboration. We have project delivery lead, which overlook on the milestones and deliverables of this project and work together with project management. We also have policy advisory board and scientific advisory board, which provide a strategic oversight on the program. So going back to in the work packages, so work package 1 is about developing rapid pathogen detection and ensure and secure border with rapid pathogen detection system. We want to establish high throughput sequencing methods as border inspection points. And to maximize the cross-sector benefit, we want to map and integrate plant health inspection together with animal and fish health inspection. And in this work package, the aim is to establish a high throughput method which has a robust and a detection technology. The work package 2 is about reducing spillover from wildlife, animals, and plants. And in this work package, we know wild animals and plants are reservoir for nasty pathogens. They jump over domestic animals and wildlife. So we want to establish metagenomic methods to identify what are the reservoir in wild species. Together with CFAS, we want to establish also environmental DNA and RNA sequencing method, which can inform us about the pathogen risk. And this is something we can work together with other surveillance programs like PathSafe and learn what are the methods they have established, and we can use these in this program. Work package 3 is about accurate genomic characterization of pathogens. And in this work package, we want to establish pathogen agnostic or targeted genomic approach, which can facilitate high confidence on samples where we don't have diagnosis reached. So these are sometimes complex diseases or complex pathogen where you cannot have a particular diagnosis. So each of the partners are biobank of different diseases, and we're gonna use those archive samples we have already in-house to establish proof of concept on those complex diseases. And also we want to establish these pipelines and implement harmonized approach to validate and accredit the sequencing methods we are developing in this work package. Work package 4 is about characterizing and controlling of emerging and re-emerging diseases. So this is, again, we want to establish metagenomic or genomic methods to actually accurately assign the taxonomic ID for important pathogens. Sometimes eukaryotic pathogen or some complex diseases, it's difficult to define what are their lineages. So we want to establish sequencing method where we can use those methods to establish where these pathogen, which lineages they are coming from. And also develop genomic data to understand what are the variants coming from these pathogens and how they are spreading endemically within UK. And also we want to develop a dashboard to support and visualize the data we are generating in this program. Work package 5 is to identify new strategy to control and mitigate endemic diseases. These are diseases which are important for endemic diseases and also have a role in industry as well, especially in livestock. So we want to use genomic methods to see and learn what our endemic diseases are spreading across and how we can able to control and mitigate using sequencing data. CFAS is also developing similar approach in water system. And again, this is we want to learn from other surveillance program which is already going on water system like PathSafe as well. In work package 6 is about community outreach and interagency collaboration. We want to establish communication channels between interagency partners, develop cross-discipline rapid simulation exercises, establish term of references for reporting policy and evidence teams, develop guidance and action plan for other genomic surveillance program like PathSafe, NBN, and so on. Also develop a data sharing plan so that everybody can access to the data we are generating in this program and benefit from the pipelines we are generating. And outreach activity like showcasing the program like I'm doing here today. In this program, we also have defined the technical domains as well. Some of these are around sampling and sequencing, data processing and analysis, validation and accreditation, and communication and policy, so that we can harmonize the approaches together with other programs already running. With that, I'd like to thank everyone involved in this program, and also DEFRA and UKRI for the funding. And thanks you guys for listening. Happy to answer you.
Oh, you guys good. Right, excellent. No pressure, Erica. So the third talk is from Erica Kintz, who's a colleague of mine at the Food Standards Agency, and she's going to talk about IID3, which is one of our big flagship programs that's running at the moment on foodborne disease. Erica, over to you.
Thank you, Rick, and thank you to the organizers for giving me the opportunity to introduce this project to everyone here. So intestinal infectious disease, or IID, presents as vomiting and diarrhea, and usually in the UK it will resolve on its own. But every now and then there will be severe complications associated with it, or even death. Even when it's mild, there are economic costs associated with it because of people taking time off work or school. And it's really difficult to know the true burden of IID that exists in the UK because of the surveillance pyramid. So most people, if it's mild, don't go and seek any medical attention from their GP. Even if they do, the GP might not request a stool sample. And even if they do request a stool sample, they might not find any pathogens causing the illness. And so that means the numbers that are recorded in national surveillance drastically underestimate the amount of IID that's actually occurring in the community. To help address this, the FSA has funded 2 different IID studies, the first one running in the mid-90s, the second one running in the late 2000s. And as Rick has already said, to update our data, we are in the middle of running the 3rd iteration of this project. So I'm going to briefly go through some of the results that came out of the IID2 project, because we're hoping to get very similar outputs from the IID3 project. The IID2 study showed that up to a quarter of the population in the UK will experience V&D over the course of a year. And that was up from the first study that ran, up from 20% of the population in the first study. 50% of the cases reported time off of either work or school because of their symptoms. And the most common pathogens that were found in the community cohort were norovirus and Campylobacter. And what was interesting is that up to 60% of the stool samples, when they were screened, no pathogen could be found that was the cause of the illness. So a big benefit of the IID studies is being able to determine the amount of underreporting that is associated with the different levels of the surveillance pyramid. And so here is the output from IID2 showing the underreporting for all IID in the UK. And it shows that for everything that's recorded in national surveillance, there were about 10 cases that were going to their GP practice and about 150 that were occurring in the community that just were not recorded. So these are the data for the 2 most common pathogens that were found in IID2, and it gives an illustration of how different the underreporting can be based on the pathogen. So for Campylobacter, pretty much everybody that reports to the GP ends up being recorded in national surveillance. And there's only about 10 cases that are occurring in the community. Very, very different numbers with norovirus. So everything that's in national surveillance, there's at least 12 to 13 people that have gone to the GP because of their symptoms, and about 288 cases that have occurred in the population. So by the end of this study, we hope to have determined, again, the overall burden of IID that is occurring in the UK since the last study was ran about 15 years ago. And again, we hope to get that underreporting that's associated with each step of the surveillance pyramid. We'll know which pathogens are causing IID in the UK, and for the first time ever, because of whole genome sequencing, we're going to know the AMR that is associated with these pathogens. And if we get enough data, like I showed for Campylobacter and norovirus for IID2, we'll also know the underreporting by different pathogens. And another aspect of the IID study is we'll know which of these have been acquired in the UK versus from foreign travel. So why update the IID data when we have the IID2 study available? One big reason is molecular diagnostics have gotten a lot more sensitive in the 15 years. So as I mentioned earlier, 60% of the stool samples could not find a pathogen in them in IID2. So we're hoping with more sensitive methods, we'll reduce that number in IID3. And as I've already mentioned, we're also including whole genome sequencing of the pathogens in this study to get an idea of AMR associated with them. Another reason is that the world has completely changed to how it was 15 years ago. GP practices are structured in a completely different way. People are interacting with their GP practices in a completely different way. And post-pandemic, people are interacting with each other completely differently. And that all might have an effect on the IID that's going through the community. And a final reason is that some pathogens that cause IID are not recorded in national surveillance. So running these epidemiological studies from time to time is the only way to keep track of trends of how often they are occurring in the UK. So this study is being funded by the FSA and Food Standards Scotland, and there is a large consortium of partners that are working together to deliver it to us, being led by Newcastle University. And this is the design of IID3, and it's been set up to be as similar as possible to the two first iterations of the project. So there are 3 parallel cohorts being studied. In the first one, our cohort 1 is a population cohort. So people are going to be invited through their GP practice to participate in the study. If they agree, they are going to be followed for an entire year and get messaged once a week to say, any V&D in the last week? If so, I hope they worded it a little bit more academically than that. If so, they will submit a stool sample, and that is going to be screened for 21 different pathogens being studied in IID3. The GP presentation study will help us determine how many people do go to the GP because their symptoms are severe enough. So if they go, they will be invited to participate, and again, they will submit a stool sample, which will be screened for these 21 different pathogens. The final one, cohort 3, the GP enumeration study, is where we're going to determine what happens in standard practice. So it's going to be up to the GP to determine whether or not they want to request a stool sample, and also up to them to decide what tests they want to run on that stool sample. We're going to collect data for 2 years for the entire project. And just to note, we're hoping to recruit 150 different GP practices for the population cohort study, aiming for about 60 participants from each practice. So this is some of the associated data that the research team will pull together to inform the study. Cohort 1 and 2 are also going to be filling out a questionnaire so that we get some idea of the socioeconomic data associated with the case, and also whether or not they have been traveling, which will allow us to determine which is from the UK versus foreign travel. And they will also let us have some idea of the household transmission, because we're going to be asking about other similar illnesses in the household when they present with the symptoms. And all of the cohorts are going to be linked with hospital episode statistics and death statistics. So the project began collecting data in September 2023, and since we want to run it for 2 years, we're going to continue collecting until September 2025. So these are the 21 different pathogens that are being studied in IID3, and these are the results for the first 5 months of the study of how many stool samples have shown to be positive. And what we're encouraged by at this point is that the number of stool samples where there is no pathogen attributable has dropped to 40%, as opposed to 60% that occurred in IID2. And so we're hoping that that trend continues and that we have reduced that with these more sensitive techniques. If you're really interested in the study, you can Google IID3 on the food.gov.uk website, where we have a link to this IID3 dashboard. It's being updated about every 2 weeks to show you where the GP practices are located and to give the results of the stool sample analysis. So what's going to happen at the end of this project? The research team is going to give the FSA the data, and we're going to use it to update our foodborne disease estimates and our cost of illness models. And that is going to influence policy's decision on what they need to do in our foodborne disease work going forward. One thing that's really fascinating, interesting about IID3 is that we're going to be the first country in the world to have ever attempted a study like this 3 times. So that means that we're going to be able to look at the trends between the different IID studies to see how IID is behaving in the UK. And a really important benefit of doing it now is that we'll be able to see if there's any new trends that have come up. That means that it's something that the FSA needs to address in terms of reducing foodborne illness. So outputs, the final report and an anonymized data set will be publicly available, and we're hoping that will be out in late 2026 or early 2027. I will note there's only been one Salmonella positive so far, but the sequence to that has been submitted to be included on the PathSafe database platform that was discussed this morning. I will also note that while they're being processed, all the IID3 samples are also undergoing cDNA and DNA extraction and being held for future research use. So if you want to go through the process of applying for ethical approval and accessing these samples, I would be the first person to contact to discuss that. We're also still holding on to the samples from the IID2 study. So again, if you don't mind going through the process of ethical approval, you can contact me to discuss research ideas and your ability to access those samples. Thank you for your time.
Thank you very much, Erica. And also pleased to say that we'll be linking up with IID3 in the continuation project, which is one of the new pilots we're going to be running. Right. Sue is back. Sue, so you're going to talk about some of your STEC work. Yeah.
Okay, yes, it's me again. I've got a different hat on now. I'm here as lead of a RESAS 2022-27 project collaboratively between Morden and SRUC with FSS as the policy client. RESAS is Scottish Government's Research and Environment Science and Analytical Services division's research programs that they run 5 years at a time, 5-year programs, primarily through the main research providers, which are the 6 Scottish Environment, Food and Agricultural Research Institutes, otherwise known as SAFARI. Why did I get up or volunteer to speak? Well, at the after the November PathSafe meeting, in various conversations, I was hearing words about STECs and looking at STECs coming out. And I thought it might be worthwhile to raise awareness of the work that we're doing in Scotland and that we have done in Scotland. Now, that then grew an arm, which was the Salmonella, and more recently the legs, which is the AMR, which I'll come on to, just to raise awareness of what we've done to help build links. So we, which is a big Scottish group involving the University of Edinburgh, Morden, ourselves, the reference lab in the NHS at Searle, and others, across the years have done a lot of STEC work in the last 2.5 decades, mostly focused on 0157. But more recently moving into the non-0157 STECs and also introducing sequencing and integrating that into the projects. Why? Well, in Scotland, we have the highest human case rate in the UK of clinical cases and 3rd in the world. And we have done a fair bit of work. We had our 3rd of the cattle surveys over the 2.5 years back in 2014, 2015. And although there's the same number of herds affected in England and Wales as in Scotland, there are very different human case rates. Why? We've been starting to unpick that. We've also used those samples to do non-0157 STEC work and to look at AMR. That's the Scottish samples. We haven't had the ability to look at the English and Wales samples, which are all archived. We've looked at the other end of the food chain at retail mints in 2019 with STEC, generic E. coli, Salmonella and Campi, and sequences from those have been fed into the PathSafe pilot that Food Standards Scotland will speak about tomorrow. Our colleagues in Morden looked at wild venison. They've been fed into the same pilot case study. And now we're doing the diversity of STEC study. It started in 2022. We're trying to fill in some of the gaps. We're using the Healthy Animal AMR survey for the sheep that I spoke about earlier. And we're looking at farmed Morden and looking at farm deer, and we're also looking at dairy cattle. So because, and we're working with Searle to put it into the context of the human and other Scottish sequences out there. As I mentioned, we're using Scottish Healthy Animal AMR survey samples, but because that's a convenient sample, we've expanded the sampling there for sheep, and we've also done field flocks. We're just working through all the lab work on these as Morden are working through the lab work on their deer farms. We're about to start work on the dairy side, and there are a number of other aspects which will have, it's research, but it probably has relevance for biosurveillance. We've looked at sequences, how you can use sequences to pull out different classifications, which Nick can speak more about. It's not my field. Morden are going to be looking at improving diagnostics for isolation, and we're about to decide on what ecosystem case studies we take forward. So that's what we're doing there. As a very small, but it is raising lots of other questions like, what do you mean by diversity? How do you interpret things in terms of the sampling strategies and the design? And what does it all mean at the end of the day? What can we actually do with it? And how do we make life better? In another project, in another topic, the animal side of things, A2, we are bringing together people who normally communicate anyway over salmonella cases within Scotland, all of which the sequences are available on Intrabase. But how do we evaluate and optimize the use of those sequences, and how do we link them to other data to do so? It's just a very small project, thinly spread over the 5 years, but it's giving us a bit of space to have joint discussions about these things. Challenges and hurdles of joining data together are just wonderful. So I mentioned at the recent B6 topic meeting, which is where the S-Tech fits in, that I was coming to say this, and everyone went, oh, can you mention our AMR projects, etc. Some of these are already linked into PathSafe. Some we've made some new links just recently. And again, this is just about raising awareness of what we're doing in Scotland. These are the legs that hopefully we can generate some more links. So B6 is a topic with lots of different projects within it. You can look at this. This is for reference later. This is how they're integrated together. The names are the lead PIs. There are lots of other people involved. And if we pull out the AMR projects, I'll just tell you a little bit about them. Mike and Leslie's project is linked to one that's also in the A2 topic, which is about informing AM use and stewardship. But they're looking at 3 different pig farms with different levels of antimicrobial use at the AMR genes on those farms, and they're also doing a risk modelling part to that project. Nuno is looking at 2 farms, a university farm and an institutions farm, AMR genes in soil, livestock and environment samples, and the co-occurrence of mobile genetic elements, heavy metals and antimicrobial residues. And the bacteria he's looking at are anaerobes and E. coli. Karen's project, which she leads, is identifying soil microbes that inhibit the range of key zoonotic foodborne pathogens, and also looking at their Campylobacter collection and the distribution and linkage, the relationship between phenotype and genotype for AMR, heavy metals, and mobile genetic elements. Lisa is validating methods of measurement of AMR genes and antibiotics in soils. They're looking at antimicrobial resistance genes in various samples from soil, water, slurry, feed, and feces, and have recently done some things with potato skins, which were quite interesting and might put you off your jacket potatoes. They were also doing participant observation of antimicrobial use, ethnographic studies coming up in human, animal, farm and urban environments looking at microbiome, sampling microbiomes. And those are the AMR ones. And then Claire and Eleanor Morden. And also Karen's doing some risk modelling as well. Claire and Eleanor Morden already linked into PathSafe Campylobacter group. They've got a Campylobacter arm where they're looking at ecosystem carriage and circulation, again on 2 farms, and Toxoplasma gondii, genetic diversity, livestock, humans and water, and intervention strategies. And then finally, our colleagues in BIOS are trying to bring us all together and come up with a framework for modelling farm-to-fork transmission and control of foodborne hazards. And that will take us through to 2027. So thank you. And hopefully, if you've got any questions, I won't be able to answer them, but I might be able to put you in touch with the people who can. Thank you.
Thank you very much, Sue. And last but by no means least, Andrew Helliwell from UKRI, from BBSRC, who's going to talk about the Tackling Infections UKRI strategic theme. Andrew, over to you.
Yeah, I realise it's the last talk of the day, so I'll try and keep it concise. So good afternoon, my name's Andrew Helliwell. I'm a Senior Portfolio Manager at BBSRC. And today I'm going to talk to you about tackling infections, which is one of the 5 UKRI strategic themes. So for those of you familiar with cross-UKRI programmes, the strategic themes are similar in scope and ambition to the Strategic Priorities Fund, and they look to address large-scale, complex national and global challenges, harnessing the full power of the UK's RNI system and underpinning key sectors of the economy. They were announced in UKRI's first 5-year strategy back in 2022, and since their launch, we've been co-creating research agendas, coordinating actions across the themes and looking to leverage additional investment. Essentially, the themes will be supporting interdisciplinary research that no individual council or even pairs of council can support alone. So the 5 themes then, building a green future, which is about delivering or helping to deliver net zero whilst improving health and the environment, securing better health, ageing and well-being, which, as it says, improving people's health whilst maintaining prosperous, productive and resilient communities, tackling infections, which I'll come back to in a moment, building a secure and resilient world, which speaks to the resilience agenda, both in terms of economic and social resilience, but also enhancing national security in physical and virtual spaces, and then creating opportunities and improving outcomes, which is about the place-based agenda, so identifying solutions to place-based disparities. So tackling infections then is driven by the challenge of infectious disease threats becoming more acute, driven by various factors, including biodiversity loss, changing climate, human demographics and behaviours, and reduced resilience, compounded by the endemic infectious disease threats to both human health and the health of the systems that we depend on, including food, water, waste, and natural managed environments. So all of which speaks to the need for a coordinated systemic response, which the Tackling Infections theme is looking to support. The intergovernmental context is also important here. So the UK, as mentioned earlier, is leading on G7 commitments to deliver effective future pandemic preparedness action. Tackling infectious disease is also essential to many of the UN SDGs. And if we are to meet net zero targets, then tackling the economic impact and the infectious disease threats on the food system is going to be critical. So in terms of the research landscape, the landscape across human, animal and plant health could certainly be more integrated and coordinated. That's true for the communities, but also infrastructures and data. It's not that the will isn't there, it's that the resources to facilitate that have been lacking. So this is where the theme is hoping to come in. And there's an opportunity on us to build on the foundations of what are particularly strong disciplines to foster more innovative thinking across the full breadth of our remit, across the different disciplines, and to capitalise on the approaches and partnerships established during the pandemic, such that the country can emerge in a much stronger position to future threats. So the tackling infections theme then has two overarching aims. Firstly, to foster the development of a systems level understanding of how these diseases emerge and spread through natural environments, agricultural water systems, supply chains and societies, and to ally this new understanding with the development of innovative diagnostics, antimicrobial toolkits, and effective tools to prevent and disrupt emergence and transmission. So before I go into the investment plan, I just wanted to emphasize the point that although each of the strategic themes has a nominal research council lead, that's more administrative. These are not, or this is not a BBSRC call, this is a UKRI call. And that's reflected in our governance. So you don't need to read all this, but I just wanted to point out the fact that we have, the theme itself is managed day to day by a programme board, which consists of representatives from all of the research councils. We also have an external expert advisory board, which again has expertise from across the disciplines to advise us on the strategy for the theme. And then we have a stakeholder forum, which has government departments, devolved government representatives and other funders who help to place the theme within the broader funding and policy landscape. Okay, so the investment plan. So each of the themes had originally 75 million over 5 years, with the intention that there will be additional leverage to that. And that's to support both new interdisciplinary activity, but also to amplify and connect existing investments. So in terms of new activity, we have two flagship programs, one on epidemic preparedness and one on AMR. The epidemic preparedness program is an interdisciplinary initiative to better understand, predict and prevent the re-emergence of diseases of epidemic potential. And so this has two stages. The first stage, which closed yesterday, is for initial investments to seed interdisciplinary teams and research ideas. So support for groups to come together and discuss what those questions are they can tackle together. This will then be followed by larger scale programmatic awards next year, so that those teams and others can begin to address those research questions and establish that networked research community. Then the other flagship is AMR, which follows a similar approach in that the initial stages are to build capacity amongst the community and try and forge a deeper integration of a wider range of disciplines across the AMR community. And that is through funding of research hubs or networks, which is undergoing assessment at the moment. Again, that will then be followed next year by more programmatic research grant awards, although members of those hubs to bid into and start to deliver these approaches that are needed. So they're the new calls, but we're also actually trying to use the investment we've got for the theme to amplify existing programs. So this is common across the themes and as a way to, in some ways, spend the money quickly, but also have quite a broad impact. So it says here is leveraging core commitments in targeted areas. So providing additional funding to existing calls such that we can increase the disciplinary scope of those calls and also increase capacity in vulnerable areas. So there's a number of recent investments here where we've done this, including the One Health Approach to Vector-Borne Diseases call, which is UKRI and Analytical, Centre for Doctoral Training in Environmental Solutions to Zoonoses, run out of Cardiff, that's the one zoo. Also international calls, so the EEID, Ecology and Evolution of Infectious Diseases call, which is run out of the US by the National Science Foundation. We provide additional funding to that. A BBSRC and MRC-led call on proactive vaccinology. Novel Technologies Mini Sandpits, this is led by EPSRC. And then in fact, the GAP-DCII programme, the UKRI contribution to that came from the tackling infections budget. And then we've also supported the second phase of the avian influenza rapid response investment, the flu map consortium. So quite a broad range of programmes here. So uniquely for the themes, actually, we've held back some of our budget so that we can take stock of and build on the key capabilities established in phase one, so that we can respond to what's been funded, whether there are any areas that haven't been lacking and that need further support. And we are currently determining and consulting with our external advisory board and stakeholder forum and wider community to identify how best to use this additional funding. I'll leave it there. Thank you.